joining me at the session this afternoon. I do appreciate that some of you will have actually put your name down today, and some of you will have been allocated. So, but hopefully you'll all go away. I'm not going to ask who, but hopefully you'll all go away with something from the session. So my name is Clara Roberts, and I'm Antimicrobial Stewardship nurse. We've got Clara with us, who is our Antimicrobial Stewardship pharmacist within North Wales. So we're from Betsi Cadwaladr University Health Board. We're based in Glyndŵr Hospital, so that's our base. So today I'm going to explain my role. It's the first role within Wales. Does exist a few in England and a couple in Scotland, and now one in Republic of Ireland. So first one in Wales, tell you about how it's kind of, what it's all about, example of how the role can contribute to antimicrobial stewardship. Over to you, we'll do at the end, and hopefully I'll shut up long enough so that you can ask some questions. So what is the problem? Well, the problem is antimicrobial resistance, and I'm preaching to the converted because you're all on a pharmacy day, so I'm sure you're all very aware of it. And what is the solution? Antimicrobial stewardship. This post is an initiative of antimicrobial stewardship, but using a nurse instead of the traditional doctor, pharmacist. It tends to be very focused within that area. So, what is the role? I've got my cards and I'm kind of going off on a tangent, and so I'm trying to bring myself back to it now. So yeah, only one in Wales. It aims, the initial aim of it was to involve nurses within the AMS agenda, but in a meaningful way, and not just about ticking a box. It's about involving them and educating them and everything that comes with it. It is multidisciplinary though as well, and it's become more multidisciplinary in the 12 months that I've been doing the role. A nurse offers a different perspective as well, so it complements. I mean, Clara and I have lots of bouncing off each other. That I have one idea, Clara has another, we meet in the middle, and we have lots of debates, so we see things differently, so it's really good for improvement work around that. So it's experience of patient care, their journey, and knowledge of systems and processes within NHS, so it's just bringing that different perspective. Features of the role is that it's predominantly quality improvement, so it's about implementing change locally, but also thinking about the national picture. Is there any way that we can get involved in the national picture? I'm so hot now, I don't know if it's the camera or not. So looking at features of the role, so qualities for this role is the ability to engage and to influence people. It's also about communication. It's key within any improvement work, understanding change and how to implement change as well within healthcare. Measurement. Now, I absolutely love measures. I love process measures, outcome measures, any kind of measure that will indicate that something is going in the right way. There's too much where we try to do things and it doesn't work, and we spend too much time, so it's about working with the IHI model for improvement. What are we trying to achieve? So it's about a very specific statement, and I worked back in the day with Public Health Wales with improvement, and this from the Institute for Healthcare Improvement Model for Improvement is what we use, and it works so well. So it pulls you right into what do we need to accomplish. How will we know that the change is an improvement? So that's about measures. It's measuring, implementing a change. It measures outcomes that are changed as a result of it. And what change can we make then? So once we know what change we can make, it's going to get to what we're going to accomplish. And if we keep going back to that, we end up with the right change to implement it. We then do small tested change, plan, do, study, act. So it's about not disrupting the service too much. It's about small, working with one patient, one doctor, one nurse, one pharmacist, and it's about small tested change that don't disrupt the service, so that we can make the subtle changes that maybe we need to make, or maybe stop it because it isn't working. We need to rework things. So I use that throughout it all. So it's not a clinical post. And I think one of the really important things with this role, with implementing change, is about being patient. It doesn't happen overnight. You have to be able to stand back and let things happen. Watch slowly for the dots on the chart going up in the right direction, and then we know that we're going in the right way. So an example of a change, I've chosen diagnosing urinary tract infection. So I started off the work with it in secondary care. So it was looking at how they were diagnosing urinary tract infections. There was, particularly with secondary care, there was a point prevalence study that we have every year, which was demonstrating that we weren't patients were on the right antibiotics. There was various elements within it, and I won't go into detail. But we found, when we were on the boards then, that they were using dipsticks. Now that wasn't part of the point prevalence survey, but we understood that they were using dipsticks to diagnose UTIs. And a point within the point prevalence survey was around samples of urine to go off for cultural sensitivity before starting the antibiotics, ideally when we can, for particular patients. So that was work that we did within secondary care. It's working really well at the moment. We're concentrating now on the dipsticks for the diagnostics. Dipsticks appropriately used. Plus, and there's some posters here that I've put together. All older patients aged 65 and above, we shouldn't be dipsticking their urine at all to diagnose a UTI. That's all evidence-based. So it's about implementing evidence as well. So sometimes we know what we have to do, sometimes we're not quite sure how. When it came to the samples, we found that, please interrupt me if you've got a question as well along the way. When it came to samples, it was like, well, why are samples not being taken? Is it not understanding the relevance of them, the importance of them? Is it that with an incontinence patient they can't get the urine, and there are pads that we've now made sure that the ward that we're working with has got. So there's lots of different ways, and sometimes we know what the outcome is going to be and what to do, like with the urine, with the dipsticks, and sometimes we don't. And then with primary care,
Why can't you use a dipstick?
Right, well there's something called asymptomatic bacteriuria, which is up to about 50% of older patients. The older a patient gets, they have, we can predict that they will have bacteria in their urine, of which when you're testing the dipstick for UTI, it's nitrites, which is looking for the bacteria. So half of the patients we know might not have a urinary infection. They might, but if it's something because they were confused and it's about assessing them for symptoms and signs and not just from a urine test. So we've got a ward whereby they've put the dipsticks away in a cupboard locked. They can't get rid of it because they need the dipsticks for other areas such as acute kidney injury they like to do. So we can't get rid of it completely, but we've got them so that whoever wants to dip the urine will justify why they're going to do it, and that's fine, that's no problem. So we are looking at the right time-wise?
It's really tight.
Oh, okay.
Just to add to your question, it was a really good question. So a lot of elderly change in behaviour or a bit more off to their usual side, people we're so used to thinking they have a UTI, and people so used to them just have a quick dip and see what they are, but actually doing this potentially avoid us to identify what the real cause of change in behaviour, and as Clara says that this dipstick is gonna come positive because 50% of them have asymptomatic bacteria in their urine, but it actually wasn't the problem that causing the change in behaviour. So Public Health England developed an acronym called PINCH-ME, stand for like medications and dehydration, environmental change, pain, etc. So by avoiding the dip and trying to look at all other reasons that leads to their change in behaviour or a bit off in their usual self, we potentially can get to the right diagnosis sooner rather than wasting a course of antibiotics and delaying the actual diagnosis.
So there's a lot to it in the background as well. It's really, really interesting.
And just by doing this one thing can change the whole course of how we manage this patient.
Yeah, and it's not a difficult change, this one either, but it is education. I've got a particular education package that's really to the point, and the staff that I deliver it to are like, and we do it to healthcare workers plus qualified nurses and doctors, and they're like, oh God, it's so logical. Why have we not been doing it the right way? It's easy to do, So it's very, very. It's an excellent change. So into primary care then, I'm starting work with a large GP practice who's quite a high prescriber of antibiotics, particularly for UTI. They're now coming together with measures looking at with care homes, so nursing and residential homes. What is it? Which of them are the higher requesters for antibiotics for the patients in relation to UTI? So that's the question. They're coming up with measures at the moment. We then are going to look at, I want to then go out to the homes and look at what their processes are, see if they've got any concerns as well, and point out just general discussion at first really about diagnosing UTIs. What are they using to diagnose their patients? Public Health Wales has a diagnostic algorithm for care homes to use to diagnose UTI. At the moment, there's work going on to actually make it into a tick box to make it simpler for them to use, and that will go with the request to the GP surgery. So there's ways around it. So we're looking at that at the moment. And also about sending samples off as well where it's appropriate, so that to make sure that again we're not overusing antibiotics. So that's it in a nutshell, but just going quickly to this bit, the 5 R's. So a lot of antimicrobial stewardship will revolve around the 5 R's: the right patient, the right drug, the right administration, right dose and right time. But really it's before that we need to look at, is it the right infection? Has the patient got an infection? Are they on the right antibiotic? But then before that again, we've got, can we prevent it? If they're being treated for UTI and it's due to dehydration, say, so we include all that within the training as well. We talk about that. So that's the 5 R's, and that, like I say, is quite key within AMS. So that's that. Just before I hand over to Clara, have we got an opportunity within Wales for this role? I'd love it to be standardised. It's something that is complemented within its 12 months of being in existence. The role is really complementing what's already going on with the pharmacists, with the doctors and whoever else gets involved. It's not just focusing, I'm not just focusing now on nurses, it's like multidisciplinary, and it's a quality improvement role. We can work within primary, secondary care and community. In England and I think Scotland, they're only working in secondary care. If we have a standardised job description, person specification and salary, we could prioritise our AMS work within Wales from this role at the same pace. We could all be doing it at the same pace. We could be benchmarking, networking, providing that support to each other, and ensuring that we've got a national approach, joined approach to antimicrobial stewardship from this, as with pharmacy, but from this role now we can do it again. Maybe it could be Public Health Wales, employing the staff that are based within infection prevention. So there's lots of ways. I don't know where's the money, who's going to pay for it, but so I'll leave it at that. My email address is here. If anyone, I'm happy to meet with people or share resources or whatever along the way. I'm going to pass you over to Clara. I did it within the 5 minutes, Edna.
We have 5 minutes left.
I hope he will in a minute.
So as the title of this session is the role of antimicrobial stewardship nurse, we want to promote this and have more of this role across Wales. So we're going to go over to you. If you were going away back to your health board or organisation, what would you tell your boss of why do we need a nurse but not a pharmacist? Because a lot of pharmacists is already doing it. What is the benefits of a nurse or a pharmacist? We have given you a few examples that you picked up from there, a few examples of what a nurse could be doing better than a pharmacist.
Or in a different way even. Yeah.
This is your 5-minute warning now.
Right. So at the moment, we're collecting the data through the systems in primary care around the prescribing for the care homes. So that is almost an outcome measure. The process measure for that is going to be, are they using dipsticks, and how can we measure that they're not when we've implemented the change. Within secondary care with the dipsticks, what they're using on the ward I'm working on is a stamp in the medical notes. So we've got a clear way of assessing, of going through all patients with, well, not all patients, we'll do it once a month on a set day, looking at patients with a UTI, and is that dipstick there? But because they've locked the dipsticks away, it's actually working. It's so simple. But with education, so we can't just lock them away and say, sorry, you're not having them. We have to do that education. So from that's just an example of a process measure, and then it's has the sample gone for cultural sensitivity? What date did it go? When did they start an antibiotic? So there's like a range of process measures, and then the outcome measure. The outcome measure for primary care will, we hope, be that there will be less. There was one surgery that said within 3 months there was 50 patients within their care homes have been given antibiotics for UTI. So we've got scope there that if we improve the process, hopefully we will see that number coming down. So I don't know, did I answer your question?
Yeah, so I guess you could do before and after studies now.
Yeah.
So you could do something like maybe a privacy benefits from reduction in antibiotic use. So you'll be able to look at direct cost benefits.
Yeah. Yeah.
Linking the studies out there as well.
Yeah. We can develop them.
Because one of the things you're going to have to do is you're going to have to say, I appreciate you saying why anyone. You're going to have to show your value anyway, don't you? So you're going to have to show those values to be able to fund these you're saving your money and you're reducing costs generally. There's added benefits. Having the nurse, I guess, is a different.
It's a different perspective, isn't it? Yeah.
I think that's the benefit of having a nurse. Is you've got very different
Yeah.
That's right. That's where we are thinking as well. Like, because a nurse, they're much closer to the patient, and with pharmacists, we're always thinking about the right medication, the right patient. But actually, with infection, it's a process. It's before that. Have we even got an infection to start with? And that bit, managing the patient, is where the nurse do better. They help with diagnostic, taking the test, the sample. So all that can be improved by a nurse that already used to doing that and have that experience, where pharmacists have not had that experience that close to a patient. They might know the idea, but to do the change, it wouldn't be the best person to influence the practice.
And I'm kind of predominantly working with nurses, but it is changing, it's evolving now that I'm working with different disciplines. So it's almost, as a clinician, you haven't got time to change, you haven't got time to make changes. So I see this role as almost kind of facilitating that quality improvement process.
Okay, if you'd like to wind up session 3, we'll be having a short coffee break.
measures.
and we recommencing session 4 at 2:45. That's 2:45. Thank you.
Not at the moment. Well, we haven't really thought about that yet, have we? Oh, thank you. Thanks for coming. Thank you, everybody. Thank you.